Hello, 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 everyone. Thank you all so much for joining us. We're going to get started in just a moment, but we are so glad to have you here. If you want to just take a moment to, in the chat, let us know your name, your pronouns, where you're joining us from, and we will get started shortly. Hello, hello. Hi, Latesha.
How are you?
Well, so we're introducing ourselves in the chat. And we are going to get started. So, hello, everyone. We're so happy to have you here today. This is an episode of the Well Project's Leadership Exchange Live. Titles episode is Black Women Living with and Vulnerable to HIV in the U.S. Needs, Priorities, and Optimal Care. I'm here today joined by Latesha Elopre, and this is going to be such a great conversation. This program today is supported through a grant from NASTAD. So, once again, we are so happy to have you here today to discuss with us the needs, priorities, and optimal care of Black women living with and vulnerable to HIV in the U.S. We're going to talk about two things: improving care with a focus on sexual and reproductive health for women living with HIV, and also overall HIV prevention strategies for women, and specifically Black women, and even more specifically Black women in the U.S. South. So can you just take a moment to kind of introduce yourself, your background, and your involvement in the care of Black women in this landscape?
Sure, thank you. First, thank you so much for having me. My name is Latesha Elopre. I am an infectious diseases provider here at the University of Alabama at Birmingham, and I mostly work at the 1917 clinic, which provides care for people with HIV, but also care for HIV prevention services like PrEP. And so I've been providing clinical care in that space. Then I also do research that tries to focus on how we can improve access and improve, I think, really community outcomes regarding HIV and the horribly widening health disparities we're seeing, especially in Black communities and especially in the South. So I'm really excited to be able to talk to you about this today. I'm very passionate about it.
And I'm so excited to be here with you today. I think it was a well anticipated conversation, one that's very much so needed, and I'm just so happy to be. So, a little bit about me and the Well Project's involvement in this work is that Um, the Well Project, is a nonprofit that serves women and girls living with HIV across the gender spectrum who are living with and vulnerable to HIV. I am here today as our program manager, also a woman with lived experience, and some of our programming, we have sexual and reproductive health programming where we're seeing, things come up such as, pleasure and sexual and reproductive rights for women who are living with and vulnerable to HIV. So that's why we're here today. And with the help of NASTAD, we are going to get this conversation on the roll. So, my first question to you is: as a woman living with HIV who was diagnosed in the rural South as a youth in 2008, I was really surprised recently when I read that in 2019, the CDC reported that 19% of the new diagnoses were in women. That really, really, really shocked me. It just seems that we are missing something. I'm wondering if you could speak to the importance of sexual and reproductive health being integrated into the care that women are receiving.
So I think what's really happened in regards to the HIV epidemic and the experience in the United States is that we're seeing that overall diagnoses are improving, but that we are seeing populations, and specifically populations of color, like Black and Brown communities, that are really being impacted. And so a lot of times you have Black women being more likely to be diagnosed with HIV. And depending on the area, it can be up to 13 times, 16 times more likely to be diagnosed compared to their white counterparts. And I think one of the issues that we're trying to understand as providers, as public health stewards, as people within the Black community is how we can improve access and improve care. And a lot of that right now is focusing on making the experience better for women when they're accessing health services and making it a holistic experience. So when you're going and you're receiving women's health care, are you being asked all the questions about all aspects of your women's health? And that, I think, includes things like trying to reach goals to prevent HIV and STIs and have sexual pleasure and have healthy relationships and be able to advocate for yourself in those spaces. So there is a push to move and have this integrated aspect of healthcare, but we just haven't, I think, reached that yet, unfortunately.
Yeah, and I definitely hear what you're saying, that holistic approach, because just one of my experiences going into an OBGYN office where I'm having, birth control removed. And this is not an HIV provider, but they know that I'm living with HIV. And just I felt the missed opportunity of a conversation about what kind of sex I was having, or, if I had a partner, prep for that partner. Like there was just no conversation, and just imagining what life could be if these conversations were had when there's an open door.
So I think that's one of the beautiful aspects about these types of seminars and these types of discussions, that you have this space where women can talk about what is it like to access healthcare, especially what is it like to access healthcare in America. And for me personally, I feel like when you're talking about reproductive health and sexual health, that's one of the most vulnerable aspects of a woman's life. And really anyone's life, that is one of the most vulnerable aspects of your life. And OB-GYNs are in this really opportune space because that's what they deal with. That's like the main emphasis of some of the care that they provide. So you are able to already off the bat be able to have the opportunity to have a space to talk to women about these vulnerable aspects of their lives, talking about sexual health, reproductive health, and what that means to them. And it's a lost opportunity, because that's the space where you can talk to women about what does it mean for you to have sexual health? What does that look like for you? And how can I help you achieve that? And that 100% would lead to, I think, better outcomes with HIV.
I mean, it feels extremely vulnerable. I mean, you already looking at everything, and then it seems like out of all places, that would be the place. And I talk a little bit about, when I was diagnosed. And that wasn't at, a OBGYN. That was at a health department where I was seeking birth control. And that just happened to be a test that was offered. Had that test not been offered, I don't know, how long it would have taken for me to know that I was living with an HIV diagnosis. So, yes, I think bringing it into all spaces would be great. Do you have a question for me?
I do. So we talked about this a little bit, but I think as a provider, one of the things when I'm talking to providers, especially OBGYNs, who I think a lot of times want to provide the best healthcare that they can. They want to provide holistic healthcare. They care passionately about women's health. When I'm talking to them, they're always saying to me, I feel like if I bring this up, it's stigmatizing. Like, how do I have this conversation and do it in a way where I am empowering women? I am respecting their goals and their wishes, and still talking about strategies like PrEP and HIV prevention and HIV treatment. And so I wanted to hear what you think is the best way to move forward. Like, what would you tell a provider the best way to talk to a patient, a woman, and women's health care about their sexual health and HIV prevention and HIV treatment?
Now, no, when we step into these rooms, these offices for those appointments, I try to remember that this is a human standing, opposite of me as well. So there are some, maybe discomfort that they may be experiencing with their own, sexual, just bringing the conversation up, period. So I think that it would be a lot of work within self first to be able to bring those conversations up in a room. And then sort of like universal precautions, you have those conversations with everyone. And I think the more often that you have those conversations, maybe the less awkward it'll get. Maybe you figure out your pitch and how you going to swing those questions to the people, but doing it with everyone because it isn't, just a certain group of folks who are having sex. It isn't a certain group of folks who are vulnerable to a HIV diagnosis. And if everyone could benefit from strategies that we have, such as, PrEP and PEP and condoms, and just the fact that someone is interested and willing to listen to your needs and your desires, I think everyone could benefit from that. So that's how I would, that's what I would say. Just start bringing it up to everybody. Let's talk about sex and pleasure everywhere.
Salt and pepper. Everybody needs to talk about that. I agree. I tell that to the providers I talk to. I'm saying, we need to, I think, normalize aspects of talking to our patients about sex, talking about sex just in community settings, period, because we don't. There's all this silence around sex and it makes it awkward. It makes it stigmatizing. People don't know how to bring it up. And I think if a provider feels uncomfortable, it also makes your patient feel uncomfortable because they can sense that as well. So I think I appreciate that perspective because we do need to be able to have these conversations in all spaces. I think the other aspect that I've also thought about as a provider is how to also empower women who are living with HIV in this aspect of being able to know that if you're living with HIV, you're on therapy, that can be something that's empowering for you. Like, how has that been communicated to you by your providers? Have they talked to you about you equals you? Has that been mentioned in that frame?
Well, I learned about you equals you from the community. I did not have yet to hear that terminology within any of my healthcare spaces. And I am a woman that has been diagnosed for over 15 years at this point. So at the beginning of my diagnosis, I remember having to tell people that it was less than a 2% chance of transmission if I slept with them unprotected and was on treatment. So less than 2% risk of transmission sounds a lot. I mean, undetectable sounds a lot better than that risk of 2% to me. Like that has increased my confidence. It has allowed me, it has made disclosure easier for me in a sense. It's definitely helped my internalized stigma. Maybe I don't, if I nick my hand in the kitchen or something and I produce some blood, now I'm not like panicking, thinking that I need to immediately bleach everything down. Because it is those internalized stigmas are the ones that we don't often talk about. You see a lot of us advocates present in a very strong, way, and we get up and we talk, but it's still pieces of that internalized stigma that shows up daily and that is definitely fed by the energy of those around you. So sometimes, provider spaces can be a space that feeds more into that stigma. Um, but you equals you has definitely helped me frame this diagnosis differently to myself and to those around me. Um, so I was gonna ask that as a woman, I mean, over the past 10 years, excuse me, the past many years, we at the Well Project and also in the broader community have been challenging the notion of reframing what risk is and what that means in terms of HIV acquisition for women and more specifically Black women. We see that focusing on the perceived risk from a provider may influence the resources and tools that a woman is given and misses opportunities for engagement of conversations. What do you think about offering all women routine HIV testing and discussing various HIV prevention tools? We talked about that a little bit and integrating into women's sexual and reproductive health care. I want to hear a little bit about how you do that, like from your standpoint.
It's hard. So I think number one, we talk about, let me back up. When I'm talking to providers and I'm telling them, like, these are the numbers, this is why you need to care, this affects our patients, we need to mobilize, you know, I had to correct myself because they would walk away sometimes and think, okay, so I need to tell my patients, you know, you are Black and you live within the South, so you're at risk for HIV. And I was like, that is not what you tell people. You don't need to tell someone, yes, you're a Black woman in the South, so you're at risk for HIV. Like, you need to move away from that aspect of the terminology that we use when we're talking to our patients. So I try to tell them, number one, we say things out of context and it ends up stigmatizing populations even more. I remember when I was in medical school sitting in classrooms and they'd be like, Black people are more likely to die from strokes. Black people are more likely for this. And I would feel like a spotlight was on me because I was Black sitting in a room where I was not the majority. I was by far the minority, and everything was negative was associated with me. And no one was putting it in context, saying things like, this is because of lack of access, racism, and structural inequities that have happened over a lifetime that are currently happening today. This is our issue, not theirs. This has nothing to do with number of sex partners you're having. This has nothing to do with your behavior. This is because of a public health system that has failed you. So typically, I don't talk about, number one, numbers and risk when I'm talking to my patients. I try to put it in a perspective where I'm talking about empowering them with whatever goals they have for their sexual health in their lives and what they want to get out of their lives. If that's sexual pleasure, if that's autonomy, if that's the ability to not have to argue or negotiate with your partner about putting on a condom, all those things. So I try to frame it that way. And then if a patient asks me, well, I read this, I want to understand these numbers. I'm hearing that Black communities are more likely to get this. And I think sometimes there's some fatalism that happens with that aspect of our communications. Number one, I say to them, I apologize to you. That has nothing to do with what you do or behaviors that we do as Black people. That has to do with the fact that we as a public health system, we as a government, we have failed you. And that's just the truth. So that's the way I try to frame it. I don't know if all providers frame things in that manner, but I try to make sure that they walk away feeling, number one, that they have the power over their sexual health, and that I'm presenting them with tools to make them feel even more empowered.
Oh, I love that. I love that. If I had a provider to, just speak to me like that, it would feel good, and it would feel that empowering as you mentioned. I did want to bring in a comment from the audience. So Lorraine says, as we know, physician education does not include human sexuality, so discussions about STIs and sexual pleasure must be incorporated there. Otherwise, the discussions must occur outside ordinary healthcare settings. I didn't know that human sexuality wasn't included in the curriculum. Didn't like, how is it not? We talk about, provider education be so important, but how are we not offering a class on sexuality or a requirement?
So I think some schools are trying to change and improve that. And I think that happens across different provider types. We're talking about nurse practitioners, physician's assistants, clinicians, every aspect of healthcare. I think people are trying to do a better job of incorporating this aspect of health in education, but we are not doing it all the way around. It's not something that is routinely tested on. It's not something that you're required to know. So a lot of times for medical school specifically, it focuses on, what do I need to do to be able to get my license? What do I need to know to be able to say, okay, I can walk away and say I'm a doctor. And I do think that we should have to incorporate that for you to be able to walk away and say, yes, I'm a doctor. I know this, and I will not harm people by not doing this well. In saying that, there is a movement to have more robust teaching around this, and making sure that this is an aspect of, I think, overall curriculum. It's just not something we're doing well right now. It's not something that's standard. So yes, that is 100% correct. And we need to do a better job of it. So a lot of times it falls on extra information that's provided by people who specialize in this at the university that you happen to be training at, who's coming to give you a talk. I learned about it working at the health department, which was not the best way to learn about it. I had to relearn some things, and that has nothing to do with health departments, just has to do with, I think, other people who were not always taught the best way to take sexual histories. So it's just a perpetuating, I think, bad system that now we're trying to correct.
Thank you for that. Thank you. We do have another question from the audience. So it is, as I work as the program manager for an HIV medical case management program with a 23% women clientele. My biggest frustration comes from the doctors continuing the stigma of HIV and using that as a reason for not giving women the most up-to-date data for women in HIV. How do I, not a medical professional, push back on this misleading information given to my women clients without them getting confused or let down? Ooh, that's so heavy. And I can speak to that as a woman living with HIV. Like, it can be so intimidating trying to speak to a provider, especially the white jacket, first of all. And then when they don't look like me, the dynamics are so thrown off that I found myself sometimes feeling small, feeling like even I, big old mouth me, don't have a rebuttal or any pushback to the things that are being said. And then knowing that if I'm feeling this way, what is my next sister that comes into this office? What is her experience? Someone who may not, stand up for themselves in ways even outside of that appointment and is extremely disheartening. The best thing that I have done for myself is to become as educated as I can and staying close to the information and staying close to my community, because then I kind of have that support. The Well Project has been a great source of information for me to be able to take to a provider, because it's not just me saying it out of my mouth. Now, somebody else agreed and we wrote a fact sheet about it. That has been helpful, but I would like to hear from you a response to that. Like, what does someone do?
I think I'm happy that you started, because I was going to ask you, because honestly, I think about my experiences accessing the healthcare system when I was pregnant twice, and feeling very vulnerable and feeling like I was being mistreated and feeling like I didn't have a voice, and sometimes one time specifically leaving a waiting room just crying in tears because I didn't feel like I could say anything. And the sad part is, at that point in time, I was a physician. So I understand I'm speaking from a place of privilege in that instance. But, CC, you and I have talked about the fact that being a Black woman and being pregnant in America is one of the highest risk factors sometimes in your life for mortality, just because of the systems that are in place that lead to Black women dying during pregnancy and while they're giving birth. And I felt like I couldn't say anything. And I think that a lot of times having someone who can advocate for you in that space is so helpful. It's not so many aspects in your healthcare system can make you feel small, from the front desk to the checkout. So all of it has to be corrected. All of it has to be trauma informed. All of it has to be correct for the best, I think, experience. But for you to be able to say, like, I can help you as a patient advocate, I think can be so powerful for someone who feels like they don't have a voice.
Oh, yes, all of the systems. When I was pregnant with the baby, I'm sitting in the lobby of the waiting room of mental health services at a HIV related provider and begging for mental health services because I needed it. And just speaking with one of the staff, explained to her my hardships. She said, "Well, why don't you have an abortion? Why are you keeping the baby?" Said, wow, like, wow, a place that I'm coming to seek, help is feeling further traumatizing. And I just couldn't believe it. And I was stuck. Like, did she really just ask me that? I want to read this comment from Marissa. A lot of these conversations around women's health, sexual and reproductive health, and the intersexuality of HIV and race and beyond are centered in an advocacy space for those involved in the ending the HIV epidemic initiative. Unfortunately, traditionally, these essential conversations are happening in silos. What new spaces that are innovative and different need to hear these topics, especially to debunk internalized stigma and provider bias? Oh, I know that we are here at the Well Project. We're trying to get in, as many HIV non-related spaces that make sense. So we've been exploring some, Black maternal and child health programmings and integrating like with doulas and other birth workers. We've been getting into conference spaces because sometimes it does feel like you're preaching to the choir. Um, but we are not, this is not the only community that could benefit from the information. I would like to hear your response.
So I completely agree. I feel like a lot of times we're all preaching to the choir. We're preaching to people who have the same beliefs that we have. We have tried, number one, to improve access and mainstream education for people who provide primary care services, for people who are obstetrician gynecologists, through CEE, CEU, CMEs, every kind of credentialing education unit that you can receive, to say, like, we think this is valuable. We want to offer this to you to make it more mainstream and to help people to be able to have these conversations. Now, is it always well received? No. I've had people look at me and say things so extreme where it's like, this is an insult to what I value and why I became a provider. All I can do is say, I'm going to keep trying. I have to try, because as long as you're trying and you have hope, then hopefully things can change. My belief, though, is that when we're talking about like systems that have taken, hundreds of years to create, and you're talking about dismantling them, it takes some time for that to occur. And you have to try to attack it on all ends. So being able to have, I think, patients and people in the community have access to knowledge and say, no, this is your right. You need to be able to go into your doctor's office and be able to say, like, I need this. This is my right. Please provide it to me. And this is the advocate that I'm going to reach out to that's going to help me have this conversation. Like, I think that's probably some of the most powerful ways to move this forward. It's going to be through having more community grassroots advocacy.
I recently just learned that a doula wasn't just for when you're having a baby, like it's through any experience. And sometimes I feel like I need that type of support when I'm going into the provider's office. Even before I get there, just making a darn appointment, I need help because that itself can be stressful, and finding care that matches how you feel like you should be treated on the inside. Like I don't feel like I deserve the worst of healthcare just because I'm coming from what is perceived as one of the worst zip codes, in my city, or because I am Black, or because I'm a woman. Like, I want the same type of healthcare them folks over there getting, where, it seems like the people really care about them, or, even in a place where every time you go, it's a different case manager or a different therapist or a different doctor. Like, what is it about me, this building, these services that are being provided that's not making folks want to stay? Because then it makes me feel like I'm just getting the bottom of the barrel, whoever, what, there is so much that goes into the care and treatment. And I don't think that we often get this space to be able to verbalize those things without sounding like the angry Black woman, or feeling bitter, or feeling like you deserving of things that you're not deserving of. No, these are actual human rights. Like, these are rights. Sorry, I didn't see a raised hand. Yes, there goes Nancy. Are you able to come off mute? Oh, let's see. can't get Nancy on. So when you can get off of mute, then I would love for you to jump in with your question or comment. Um, so I'm going to jump into a next question for you, Latesha. So while moving towards more of an understanding of the importance of the reasons for HIV prevention in women's lives, it's important that this is framed in a way that makes these conversations happen. As a provider, how does that framework present itself in your work? And I think we've kind of touched on it, but what recommendations would you have for a colleague of yours that was having, more trouble having these conversations?
I think that I ask my providers who are having issues having these conversations. Number one, it's important to do internal scans first. So we always tell them you need to understand what your biases are and check them. So what you go into the room, you understand like this is a bias I have. I need to understand that I have this bias and I need to correct my behavior to address the bias I have. Everybody has biases. You just do. And it is uninformed as a provider, as a human being, to not like think about what those could be and how it impacts, especially the care that you provide somebody. So that's why I tell them first. And then I say, we actually need to practice. We need to do cases. We need to actually have you think about what you would say in these situations. So a lot of times we do like case-based series and lessons where we say, okay, you have a patient coming in today, and this is what they're coming in talking to you about. What would you say at this point to give them counseling about their sexual health? And then we have them do their example. A lot of times it's actually quite interesting. They're usually nervous. A lot of times their voice is shaking. Like it's a hard conversation for them to begin. And then we say, okay, let's stop here. Let's talk about the things that you did well, but let's also talk about ways that you can improve. How would you feel if you were in this situation and someone said this to you? Do you think that the outcome would be the way that you want it to be? And I think that helps sometimes. At least that is our goal, is to have it help. But I think practice sometimes makes makes perfect. If you can practice something, if you can try to make sure that you're doing it in a way that's humble and you're constantly just trying to improve yourself, then hopefully you become a better provider that's offering holistic sexual health care.
Yes, yes, yes. I saw both they said most women are so ashamed and afraid of discussing this topic. And I can definitely I can relate to that, but I can also relate to just if I had the information, like if there's a poster on the wall in the doctor's office when I'm just waiting on them to come in, I'll sometimes take a look around there. If I saw that something like PrEP or PEP was available to me as a person before I became positive, maybe that would have sparked a conversation when the person came in the room, for me to learn a little bit more about. And maybe that could have been a tool that, now I would not be living with HIV. Or I've heard stories of people trying to access tools, and because of those biases that you just spoke about, I've heard that providers said, no, I will not be prescribing you this. And if you want that, then you'll need to go somewhere else. And how discouraging is that for someone to, want to take control of their sexual health in such a way and then be turned away by a person that you're supposed to be able to trust, and get care from. It it can be it can be a difficult path to navigate when you have knowledge and you have wants and desires and it doesn't necessarily match for the folks that are seeing you.
So when women that have experienced those types of traumatizing experiences in healthcare settings, which is supposed to be like, that's supposed to be a safe place. It's supposed to be a place you go and you feel like I can be vulnerable in the setting, and you try to advocate for yourself and they try to advocate for themselves, and you're met with such a bad traumatizing outcome. What typically happens? Like, have there been good examples of how providers talk to women about PrEP?
I know a few women that are on PrEP and that have been able to access that. So we're getting it, the ones that actually are that hear about it, because I often hear that as well too, is that Oh, I didn't know that there was something that was available. So when those situations come back to us as a community, oh, that provider didn't work. Well, let's go try this provider. Maybe does anyone know of a provider, in this area that will prescribe PEP and is kind of using that network that we've been able to build out. But without that network, it can be really isolating and lonely, and you don't really know where to turn. So many great resources are being put into the chat. Um, oh wow, I see a comment that says I travel over 700 miles to get healthcare I'm completely comfortable with. That's outrageous. I mean, I love that you are able to do that, but it should be closer than 700 miles like that because we all need healthcare. Um, Let's see, where do we want to go next? Marissa also put in some trainings here, so make sure y'all keeping up with the chat. And I just want to throw in here that we will be having a survey offered at the end of this webinar. We would love for you all to take a moment to complete that so that we can continue, providing our community with programming that is appreciated, needed, wanted, all of those things. So keep an eye out for it. Do you have anything you want to ask me back or let me
That's
keep
the thing I
going?
want to ask you, and I also want to give a shout out because I was watching the chat too. Like it's amazing. This is a great, I think, example of people disseminating best practices and disseminating information. So I want to give a shout out because I do know Dr. Whitney Irie. This is a great training session. She's wonderful. And the work that she does is so powerful. So that is something that I've actually been able to witness and I have just found to be amazing and allow a lot of people are trying to access that tool to learn how to give better, I think, culturally appropriate and humble care. So I just wanted to give that shout out. And then I did want to ask a question. And I think the question I really wanted to ask is something that I've struggled with the most. I mean, honestly, and I think that is in regards to some new guidelines that have come out that I think are great because it talks about the importance of shared decision making in regards to talking to your patients if they are living with HIV and they are breast or chest feeding about whether they want to do that, if that's part of their goals, and then how you can, I think, give them the best recommendations possible in doing that and try to do harm reduction in regards to not doing things that will harm the actual patient, the mother, as well as their child. But I want to talk to you a little bit. I want to understand like your experience, like what do you think and what do you think we could do to be improving aspects of talking to women about this, I think, most vulnerable aspects of their lives. I know it was vulnerable for me, but this aspect of when you've had a child and you're trying to make a very difficult, I think, choice a lot of times.
So what that looked like for me was just like my autonomy, my ability to make whatever decision it was that I wanted to make. Living with an HIV diagnosis for me kind of came with some restrictions. Like I knew that it was going to be things that I was no longer allowed to do because I was living with an HIV diagnosis. And that perception and framing in my head has been limiting because I'm allowed to do whatever I want to do. Now, what the repercussions of my actions are is something's different in different parts of the world for different things. The consequences and re repercussions could look so much different. And I just want to be able to make my own choices. So if I want to have sex with a condom, I want to know what happens if I don't have sex with a condom is what percentage, risk is it that my partner would get it? What happens if I take my medication? Is there anything that they can take so that a transmission doesn't happen? What happens if I want to breastfeed? Are we seeing other parents? How come I get to see her over there breastfeeding? How did she do that? Why is it so different here? I want to be able to take those questions to my provider and ask and not be judged just because I am asking. It's a question. Maybe I'm exploring, playing with different things in my mind, which I'm allowed to. I'm a human. I'm a woman. I'm, I'm living with HIV, but that does not take away my desires to want to engage in sex. It doesn't take away my desires to want to engage in all of what life has to offer me. So, as a provider, I just feel like their role in my life, because I've chosen to come to them for care. Like I know that I need this care, but I've chosen you. I've entrusted you with it. I just need you to give me all like what the 411 is on everything and allow me then and support whatever that support looks like. And if you aren't the one to be able to provide this support, please do not inflict further trauma and pain. Send me to somebody else. Go ahead. Maybe this, I'm not comfortable here, or whatever way it needs to be worded, but don't hold me back just because it doesn't align with what you feel like my life should be going like.
Every time I hear you talk about this, I always feel like crying because it's so powerful, and I feel like it's such a vulnerable part of your life to be able to have that kind of conversation with a provider about something that can be, I think it's supposed to be a beautiful aspect of your life, and it can be so traumatizing. The idea that you, if you want to, are being told not to breastfeed. If you are having trouble and you don't want to, you're being told you're harming your child. The aspects which I learned from you, that some women were having child protective services called on them in this safe space. And I think a lot of times we write these guidelines, especially when it comes to that vulnerable aspect of women when they're postpartum, but we don't take into account what it means for that woman to be postpartum and how vulnerable you are during that time, and how I feel like a lot of times healthcare systems forget you. I speak on that personally. You feel like you're forgotten. And I can't even imagine how that's magnified and how that was magnified for you as a woman with HIV. So I always appreciate listening to your story. I would appreciate you advocating for women in that space. I can't even, I don't know. I don't know.
And I loved, we talked about this being able to, that is a commonality. Like we're both Black moms living in America. And it's taken me some time to realize because I've been positive so long. Like I was 20, I was just getting to adulthood. Oh, it might not be my HIV that's showing up first in the room. I'm showing up first as a Black woman. Oh, so that's why our experiences are so similar. And then it is compounded by the HIV status, which just to me, sometimes it feel like the bottom of a totem pole that shouldn't even exist. Like the bottom, my once like I don't have a say so, y'all using all these different types of words in this room in front of me that I don't understand. Y'all having conversations about me. I felt like a spectacle since the beginning. I felt like people were just trying stuff, trial and error. Put on a study that maybe there was a study I was taking some free medication for some time, but I don't know. I feel like it took me a really long time to get in line and understand the care that I was receiving, the fact that I could even advocate for myself in, any type of way to get closer to the care that I was hoping to receive. So let's see, there's so many things going on. Do you have anything to add to that? Because there are more comments in a
No,
second.
I just think it's beautiful. I appreciate you sharing your story. I appreciate it.
Thank you. Um, so here's a question. I'm a health educator at my local health department. How do I encourage nurses in our family planning clinic to have conversations that inform patients about PrEP? Or how do I get information out to our patients?
So I can say when I've talked to women about how they want to receive PrEP information, and this is, women that I've talked to in Alabama, they said they want to receive it from everybody, like from every aspect of their healthcare. They want to be able to hear positive messaging from the medical assistant, from the nurse, from every person that they touched. If they wanted to ask a question about it, like, because people seek health information from all aspects of their healthcare team. So in saying that, I feel like a lot of times nurses are the main powerhouses of the healthcare team. Like they're the ones who are the biggest advocates. They're the ones that are holding it down and making sure providers are doing what they need to do. I had I had a wonderful experience in regards to being able to work with nurses who are advocating for patients and patients' rights. So in saying that, I would say that there needs to be specific lessons and I think educational material, specifically talking to nurses and to that part of the team that isn't always provided that educational content, saying like, this is how we want to make sure you know information about PrEP and how you can communicate with patients about it in an empowering way. And also understanding like what their workflow looks like, how that might look for them, and how they want to deliver that messaging themselves. So I think it has to be like a bi-directional communication, but it's something that's definitely needed because I think patients want it.
No, we absolutely want it. And I think it's beneficial. I know that, the posters in the room, they got brought back up in the comments. I think that there is a great space. It just made me feel good. I was in a pediatric doctor with my kids, and on the wall there was a prep poster. It was a black mother, a black child, and it said something about I prep because I love or something like that. And just, something subtle like that. You pull out my phone, Google what prep is if I don't know what it is. And definitely nurses and that desk staff and everybody just knowing, being in tune with who you are serving, I think is extremely beneficial. Sorry, excuse my background for a moment. I am going to read this comment. I'm sure I'm not alone that doing this work can be very rewarding, but also daunting. If we can do more work together, we can truly make a difference for ourselves, those we serve, and those that will come after us. If people want to get more involved into this work um, to help create more spaces from advocacy, community, academic, governmental, or clinician perspectives, are there any current spaces that are interdisciplinary that you would like to uplift? Any conferences where folks can engage more, or any efforts we can all work more together on? Hashtag nothing for us without us. Hashtag we are family. I love that call.
That's amazing. It's actually interesting. Most of the spaces I know are somewhat siloed. I'm gonna be honest. Like it's usually I'm talking to the American Association of Family Practitioners. I'm talking to like a specific association of providers or a specific association of nurses or a specific association of medical assistants. It's not always like this beautiful interdisciplinary space. Now, there are some talks that people can sign up for, like clinical care options, practice point, well project, where you can have, I think, spaces created that are purposely supposed to be interdisciplinary, that offer all different types of educational credentialing and credits. And those sometimes I think can be powerful, but I think we have to make sure that they're getting out, like you said, to everyone and not just to people who are already invested in this type of work. So I do think that's an important point, that we don't always have these empowering spaces where we can all hear information, share information, and learn from each other. It could be beautiful. And I want to comment on something you said, Cece, which is having this in the pediatric space, because we don't talk about that either. And it definitely should be, as my mom says, from the womb to the tomb, like you need to have sexual health in
Yes.
every facet of your reproductive life, and that is from the time you are born to the time you die. We are reproductive sexual beings. So
I did a training one time where as a grown woman with one child, married and divorced, we talked about our vaginas and like a diagram of our vaginas, and everything had a name. Like there was a vulva, there were labia, and the amount of women, including myself, in that room that were not even able to name all of the pieces of our anatomy. like was surprising. I was surprised in myself because I had already been using this joint. This joint I've already, contracted HIV and I can't even name my body parts.
A lot of women can't name their body parts. This is again a failure of us at, and I say us, I mean providers, public health. We have failed our patients. The educational system in America has failed our children. I'm just going to say it. I've had patients where I start talking about sex, and they don't know what I mean when I say, have you had vaginal sex? I had to go back and stop myself and make sure that I'm leaning in and trying to educate them on what is an anus, what is a vagina, what does it mean to have sex in those places. They don't know. They don't know. They don't know. It's just utterly profound to me that we don't talk about these things, and we don't talk about it with everyone because we should be. We should be talking about this with everyone. So I think we could be doing a much better job of that.
Thank you. Thank you. Thank you. And just to remind everyone about the survey after this webinar, and that the Well Project is currently working on some talking points for providers that'll be both on sexual and sexual health and pleasure, excuse me, as well as incorporating HIV prevention into women's overall wellness discussion. So Krista says, stay tuned. And while we touched on it a little bit, but beyond infant feeding, maybe we could talk a little bit more about family planning for women living with HIV and the state of Black maternal health. And then even with the other layer, talking about the South. So what does family planning look like? I know that when I got pregnant, I'm not in the South anymore. I got pregnant in 2021 and still a childbearing age. I was 32, 33. And I was on a medication that on the side of the bottle, it said not recommended if you are pregnant or thinking about becoming pregnant. And I couldn't figure out how I ended up on that medication without a conversation from my provider. That was one of the, that could have impacted me and, whatever kids that could have been coming. So what does family planning even look like?
So I will say, as a provider, we don't do a good job when we are providing care for people with HIV, talking about reproductive health. I think a lot of times provider bias plays a role where we, number one, make assumptions where it's like, oh, I'm not going to talk about family planning up front. We need to talk about all aspects, all goals in regards to livelihood and what you want in regards to your life. So we could be doing a much better job with that. And I want to say there's another layer in the South, in a lot of Southern states, when you're talking about family planning, with the aspect that if you don't want to become pregnant or you have an unexpected pregnancy and you don't want to continue that pregnancy, that's not always an option for you. So it is a very important conversation, I think, to be having, especially in states that may be more restrictive and be penalizing women in regards to their bodies. And so with that, I think that makes it even more important that we're having these conversations right now. We're having it in these spaces, and we're talking and educating providers about how to make sure that we are empowering women, saying, I want to understand what your goals are. What do you want? And if having whatever family looks like to you in the future as a part of that goal, then what can I do to make sure that you reach that goal and you reach it to the best of your abilities? So I think there's just aspects of healthcare that, again, we could be improving, and we probably could be improving it by improving education that we receive in pre-K to kindergarten to middle school. But definitely, if you are in medical school, you should be receiving it. And so hopefully we'll do a better job of that in the future.
Yeah, because I was thinking how you know, just the range of other people's opinions and thoughts on the reproductive rights of people who are living with HIV. And I do some online advocacy, and to hear the comments come from a community outside of folks in the HIV community, the opinion of, why are you having kids? why are you being so selfish? Who would sleep with that? And then to come to the other end of the spectrum, folks who are specialized in HIV care, um, or sometimes not even specialized, the folks that are providing some form of health care to also hold some of that same, feeling. It is scary, and is very scary because you don't know who you can trust. Like, because I'm expressing this to this provider that I want to have children, are they going to then start surveilling all of my choices? Are they going to start, trying to push me in one direction versus another? Are they going to give me all of my options and let me know? Um, it can be a balancing act sometimes that is hard to navigate, extremely hard to navigate. And that support from the provider community, I think, is something that a lot of us depend on, even when we don't trust it.
And I'm sorry that you've had that experience. And I feel like it's something that a lot of times you have to break down, because a lot of people I care for will come in and they'll assume that they can't have children, that's just like, it's just done, it's the end. And it's not. um it's not. So I think, again, we have to work on making sure that we're not perpetuating harm, because I think a lot of times with HIV, there's already so much stigma associated with it, and there's so much, I think, internalized stigma, like you said, associated with um, getting a diagnosis. And our job is not to make that worse and amplify it. Like, our job is to help people live healthy lives and help you live the life that you want and what health looks like to you. And so I think ultimately it's moving in the right direction. Again, I like to have hope, because that's what we're supposed to do. We're supposed to hope for the future, because if we don't hope for it, then there is no future. But all I can say is we have to continue to try. We have to continue to advocate and fight and make sure that we're not creating spaces where more harm is being done to individuals.
Still on mute. We're coming to the end of this wonderful, powerful, impactful conversation. Thank you so much for having this with me. Is there anything that you would like to add that you maybe didn't get to say earlier?
No, I just want to thank you. I feel like I always learn so much when I talk to you. I feel like it's just such a privilege, and makes me feel like, it makes me feel good to be a provider, good to be in this space. So thank you for having me. I really love being here.
And I feel the same way because most providers, I don't feel like I could go and talk. So more of these conversations, humanizing and just we need more of this, and I'm so glad that the Well Project has the program in to support it. So thank you all today for joining us. Make sure you do take that survey. The link has been put in the chat a few times, and it will also pop up when you leave this webinar today. We're so grateful to have you here for today's conversation. Black women living with and vulnerable to HIV in the U.S. that needs priorities and optimal care. We're so grateful, and we hope that you have a great day.
Thank you. You see all the hearts flipping through. It's so nice.
It is. Yeah.